Hello, I'm Dr. Maureen Markman from City of Hope. And I must say, in the last two segments, I've sort of provided disquieting description of the current state of decision support in oncology because of the incredible amount of information, value of information is available, and it's only going to increase. And then considering the impact on patients who are often elderly or taking medications for relevant comorbid conditions, how do we opt to take care of our patients? It is important to acknowledge that efforts are being made. We certainly have great attempts, NCCN guidelines, for example, or a variety of clinical pathways, but they simply scratch the surface. Yes, they can tell you, what regimens may be considered, but how to optimally use those regimens, particularly when it's choice of one of four. And they certainly don't get into the third, fourth, fifth line therapies as, again, cancer becomes a more chronic condition. We know that these guidelines are not having the impact they should. I use for an example, data that have looked at electronic medical record data. For example, the percentage of women with ovarian cancer who have had BRCA testing, somatic and germline, which has been recommended for more than a decade in this setting. We know that in many areas it's been shown that less than half of the patients have had such testing. And it's not because oncologists don't want to do their best. They are overwhelmed. They may not remember, they may not do it because they see the patients so infrequently. The point is, we need to come up with another approach to the management of our cases from patients from a decision support perspective. We are going to see more tumor agnostic approvals by the FDA. We can be certain of that. We know that our patients are going to continue to come from the elderly population with comorbidities and other medications. And finally, I mentioned the absolute giant in the room, which so few can currently consider, and that is the soon to be relevant onset of pharmacogenomics and the impact that information is going to have to our use of a variety of drugs in the cancer and the non-cancer space. But again, I emphasize, it doesn't matter if you're a cancer doctor, you're going to be caring for people with comorbidities who are going to have these variants recognized that may impact the therapy that you're giving or another doctor's giving, and you've got to consider that. How can all of that information be put together to optimize the care of the patient you're seeing in the clinic today? And by the way, for maybe only 10 or 15 minutes. The answer, and I certainly do not mean to be flippant in the next couple of minutes because we're going to have to talk about this more because it's so important. But the answer, in my opinion, is AI. Of course, we can say the AI is claimed to be the answer to everything, but consider what I've said up to now, the mass amount of data that needs to be assimilated. Think of an AI solution that could analyze the multiple variables I'm discussing, the drugs available, their toxicities, the patient's history, all the laboratory results are available, the pharmacogenomics, which could be analyzed. And as the patient's condition changes or new medication they take, that can analyze all this regularly, quickly, provide suggestions to the oncologist to consider as they treat their patients. Advise the oncologist, not to tell them what to do, advise the oncologist. They can make recommendations for follow-up tests, the impact of the pharmacogenomic profile if a drug is given or a drug is being considered to be given. Consider the toxicity experience of the patient, the toxicity experience just reported on this current visit, and any changes in the patient's clinical status. To be clear, what I'm proposing is incredibly comprehensive, very complex, and we are talking about a very evolving area that is AI development. But we are talking about looking at all the information that is valuable in the literature, combine that with laboratory data for the individual patient, the medical history, patient-reported outcomes, to try to assist the oncologist making the best decision visit by visit, week by week, maybe even possibly day by day. Just two more questions to be addressed. They're very high level. First, what I proposed, who would pay for the development of such a schema? Who would pay for its maintenance? And who would pay for all the upgrades that will be required as there's evolving information that comes along? And finally, who would pay for its use? But in conclusion, I return to my favorite philosopher, Yogi Berra, whose profound words, I think, summarize the essential next steps. When you come to a fork in the road, take it. And I thank you for your attention.